Very good afternoon, everybody. And this is another session of IC, Unexplained to Explained Decoding Visual Loss. I am Dr. Dr Prasad, Chief Instructor. And we welcome all the speakers and all the delegates over here. Please come on over the dais. Dr. Rajesh, Dr. Garima, Dr. Hindu, Dr. Abhijit, Dr. Anita, please. You must be encountered in day-to-day practice to have unexplained visual loss. The vision loss could not be corroborated in any sense to the amount of visual loss. So, any structure abnormality. So, this is a good IC to have some take-home messages and. ऊपर आ जाइए. We have a galaxy of speakers. Dr. Rajesh Shah, who is a trained veterinary surgeon, trained in one of the premier institute of the country, have vast experience of real world scenario in managing veterinary diseases, and very active academically in state and national conferences, have publication in international and peer review journal, and runs Lucknow Eye Center, Lucknow. Another learned speaker is Dr. Indu Pandey, very experienced surgeon, graduate and postgraduate from NSCV Medical College, Jabalpur, practicing since last 75 years, have very academically active in all the forum. Dr. Anita, who is an additional professor at IOC, a special interest in the area of neuroophthalmology, who will be decoding the neuroophthalmological cause of the unexplained visual loss. Another, Dr. Garima Chadda, he is a MS ophthalmology and veterinary fellow, have vast experience of 16 years and working in Nagpur. And Dr. Abhijit Chattopadhyay, who is an experienced veterinary surgeon and working at Priyambada, Calcutta. So my topic is how to make history extracting to clue to the diagnosis. So I have no financial disclosure. Unexplained visual loss is one of the challenges faced by the ophthalmologist, and it is defined as a decrease in the best corrected visual acuity, which cannot be explained by underlying pathology of visual pathway or in and out of proportion of identifiable lesion or obvious structural changes in the visual pathway. So before going for the diagnosing as a case of functional visual loss, you must look for the pathology, because once you labeled as a functional visual loss, all investigation ends and treatment strategy and loss to the patient. So you have to carefully look for the any pathology, ocular or non-ocular pathology, before labeling as a functional visual loss to the patient. And there is I don't know if there is no definite protocol available in literature how to proceed for this entity. According to Scott and Egan et al., as 2003, more than half of the patient with functional visual turned out to be the organic cause. So we must look for the causes and all. As you know, once patient comes with decreased visual acuity without a countable structural abnormality, following data were collected from the medical record of the patient itself, like demographic information, it plays an important role in localizing the which disease is prevalent in that area, and the pattern of the decreased vision. Initial best corrected visual acuity must be ascertained from the previous data whether patient is having how much vision was there previously going for the visual loss. And duration of the symptom is very important. Time to first visit to the presentation is again important, because it denotes the seriousness of the disease and seriousness of the patient too. And the number of workup done must look for, and because you need not to evaluate, go for the another workup, and you can find the clue on that workup only. And an amount of money spent by the patient is important, because financial load should be less to the patient. If we have a review of data, go for the ophthalmic examination. What we have in hand is slit lamp examination, including 90 diopter lens, relative apparent pupillary defect, Goldman apprehension tonometer, ocular mortality examination, including cover, uncover, and Hertzberg's tests to look for the any deviation of the eye. That could be the myopic, and fogging test should be done to rule out whether a patient is having a functional loss or not, and for DOS or for prism diopter test to look for the monofixation syndrome or microtropia. 4 degree of 4 prism diopter test would be done in those cases. So once you have not made conclusion on this examination, you can subject the patient to the investigation. What we have is array of investigation like OCT, RNFL, macula, fundus fluorescein angiography, visual field, ARG, EOG, VEP, MRI. But the OCT is a mainstay of the treatment nowadays, and you can extract maximum information from the OCT. The cornea, lens, vitreous, retina, optic, visual path, all should be okay to have a normal visual, but sometimes we could not find any obstruction or abnormality, and examination posing a problem in determining the cause of the decreased vision. Eliciting the cause of the is important before labeling as a functional loss, visual loss, as it helps the process of investigation and further planning of treatment. At the same time, it is also important not to subject unnecessary investigation which have adverse effect on the safety and finances of, of the patient. And the best way to lead the investigation in a proper direction, which way to go for the investigation, is history taking, which is very important. And there is no fixed protocol or guidelines available in literature about how to proceed in the patient of the unexplained vision loss. So triaging is important. It helps in finding the cause, it helps in guiding proper investigation, saving necessary expenditure, and helps in finding out non-orthogonal cause of the decreased vision. So once patient come to your clinic, don't rely on the vision recorded in the other clinics, which may be inaccurate. Always do it by yourself, and don't rely on other vision record. So a patient often comes with decreased vision of the recent origin, because on careful questioning about the duration revealed diminution vision since childhood, but have increased concern recently. So establishing the diagnosis of amblyopia, and you can help investigation accordingly. Fluctuation or intermittent diminution vision raise suspicion of the OSD. Malingering is one of the main cause of unexplained diminution vision, 5 to 12% of all cases. On the other side, Scott found et al. Found that 53% of patients of functional vision loss found to have concurrent organic pathology. So far as a non-retinal pathology include repeat visual testing is important. Retinoscopy to look for the form first keratoconus, microtropia, cataract mild. If you do the distant direct, you can reveal the information, and malingering. So, and other neurologic causes include the ocular macular dystrophy that can be revealed with the OCT, careful examination. Retinal dystrophy, history of night blindness, and ERG can reveal the, in a normal looking fundus have some kind of CSNV kind of thing. Shallow central chronic central retinopathy can be seen in OCTFA. And you important thing is you have to have history of any melanoma associated retinopathy, or patient is suffering from the cancer or not. So these two are the finding leads to unexplained visual loss. Past history of head trauma is very important, may lead to damage in the neural pathway. Masquerader of the non-organic visual loss is occult macular dystrophy, cortical visual impairment, and inherited optic neuropathy and autoimmune retinopathy, which can be seen in the cases of any cancer-associated disease. So this is a algorithm. You can, if patient comes to you, recheck VCVA, retroillumination, see of the Royal cataract or any media opacity, retinoscopy to rule out keratoconus. If you are not, if a mild visual symptom is there, and changes with the blinking of the eye, IOSD bit offset can be made. And then you well performed OCT read by the expert. History of head injury is there, then go for the VEP. If history of suspected malingering, just a couple of seconds. Back, back. Uh-huh. Yes. Go for the suspected photophobia, personal history, family history of RP, night blindness, go for the ARG. If no history there, a specific pattern of optic nerve you are seeing or any CNS history, then go for neuroimaging. And if you are non-specific anything, go for VEP. It is normal, then rule out malingering, and if abnormal, rule out old vision loss with the recent awareness, and amblyopia, which I have already explained in our previous slides. Microtropia or monophilic cessation filament, if it is not there, go for neuroimaging. So important decision making, Patient with unexplained visual must be seen in a totality. Presenting complaint must be listened carefully. General condition, you have to take into consideration physical condition, psychological condition, history of accelerated hypertension, cardiac condition, treatment taking, and chronic headache, history of injury, birth history in females, facial conditions, must look for optic disc pallor or temporal error, professional history and family history should be taken in totality. So at the last, visit technique is an important tool to give the direction towards the proper investigation and save costing, discomfort to the patient, distress reduction while awaiting reports, decreasing side effect to the procedure. Thanks for your patience hearing. Now I call upon another speaker, Dr. Rajesh. You are in the line. So we will, if you have any question, we will take a at the end of the